start, sir.
Yeah. Hi, very good evening, doctors. Today we are we have connected to discuss few scientific topics about aflibercept data. So in this meeting, two eminent speakers were speaking. Our first speaker would be Dr. Skanda Harshita madam, and the second speaker would be Dr. Annaji Rao sir. So first talk, we will go ahead with Harshita madam. So to introduce Harshita madam, uh, madam has completed her vitreoretinal fellowship at the prestigious Arvind Eye Hospital, an institution that needs no introduction in global retina care. For the past 4 years, Madam served as consultant in vitreoretina and EVIA at Pushpagiri Vitreoretinal Institute, Vijayanagaram, where Madam manages a high volume real world retina practice. Dr. Harshita Madam, clinical passions are particularly relevant to today's topics like complex diabetic vitrectomy and retinopathy of prematurity, two extreme two extremes of vascular retina diseases that demand precision, persistence, and a deep understanding of angiogenesis. So that surgical backbone gives Madam a unique practical lens through which she views the long-term management of diabetic macular edema. Beyond her clinical work, she is known for her sharp, evidence-based teaching style, and her commitment to improving diabetic eye care. So, with this, I would warmly welcome Dr. Harshita ma'am to start your first presentation, madam.
Thank you, Srinivas Garu, for the introduction. Um, am I audible?
Yes, ma'am, you are audible. Please share your screen, madam.
Sure. Is my screen visible now?
Yes, ma'am. Yes, ma'am.
Okay. Okay. Good evening, dear colleagues. Today's topic is about translating research into practice in the context of diabetic macular edema. I don't think my slides are moving.
No, ma'am. Slides are not moving.
Okay. I'll reshare the screen again.
Yes, ma'am.
Hello?
Yes, yes, madam. Screen is not shared, ma'am. Not yet shared.
Yes, yes, yes. Srinivas Garu, do you have my slides I have sent you? I think
Shall I share
yeah,
the slides,
you
ma'am?
have my slides. Yeah, yeah.
Can you share me once now, ma'am, if possible?
No. Okay, sure. I have shared you on WhatsApp, please.
Yes, ma'am. One moment.
Yeah.
Can you retry? Meanwhile, can you retry once again to share your screen, madam?
I think I have to log out and log in back again.
Yeah, yeah. Please log out and
Shall I
log
do
in
that?
back, madam.
Yeah,
Because
yeah,
because
yeah, I'll do that.
it will be easy to
Yes,
change the
yes, yes,
slides.
yes. Deva Faru, can you share my slides, please? Not able to log in.
Okay, madam. Give me 2 minutes, ma'am. I'll share.
Sure, sure, sure.
Meanwhile, setting up this, madam, if you're okay, I'll ask
Yeah,
Annaji sir to proceed with
yeah, yeah.
the
Sure, sure.
presentation.
Sure. Meanwhile, I'll share my
Yeah,
screen.
yeah. Annaji sir, is that okay, sir?
Sure, sir, sure.
To introduce Dr. Annaji sir for our next presentation, Annaji sir completed his MBBS and DNB fellowship from Vitro Retina and UVA fellowship from Arvind Eye Hospital, Pondicherry. Now working as senior vitreoretinal and UVA consultant at Shankar Foundation Eye Hospital, Visakhapatnam. Sir having special interest at managing intraocular foreign bodies endophthalmitis, and complex tractional retinal detachment surgeries. So, with this, sir, I would like to welcome you to share your screen and start the presentation, sir.
Sure, sir. Thank you for your kind introduction about me.
Thank you, sir.
Uh, can you see my slides, sir?
Yes, sir, it's visible. And you are quite
Yeah.
audible.
Okay. Good evening, all. Thank you for giving me this opportunity to present here. The topic is the evolving role of aflibercept in PCV, APVRS insights, and comparisons with anti-VEGF agents. Aflibercept monotherapy achieves clinically meaningful visual outcomes in patients with subtypes of neovascular AMD, such as polypoidal choroidal vasculopathy, known as PCV. So APVRS guidelines update 2025. PCV diagnosed with SDRSS OCT. The major criteria is sub-RP ring-like lesions. On NFOS OCT, complex RP elevations and sharp peaked PEDs. And confirmation by either multimodal imaging with fundus fluorescence angiography and ICGA with addition of SDRSS OCT and OCTA. Initial treatment usually followed with anti-VEGF monotherapy or combination with PDT. So we monitor treatment response with usually OCT and in rare cases FFA or ICGA. We see complete regression or stabilized SRF. Usually we extend the treatment intervals with the treat and extend regimen. If any persistent or recurrence of disease activity, we can shorten the intervals with the treat and extend regimen or combination with the PDT or switch to another anti-VEGF agent. If there is a large submacular hemorrhage due to PCV, we can treat with pneumatic displacement with or without TPA or plus or minus vitrectomy. If active extrafoveal polypoidal lesion present, we can go with anti-VEGF with thermal laser ablation. So 2025 APVRS guidelines, monotherapy with anti-VEGF treatment is effective in many cases of PCV and can be used initially as monotherapy. To date, there are no data exploring whether faricimab or brolucizumab monotherapy are non-inferior to combination therapy in patients with PCV. Summarizing of the molecular properties of currently available agents, we usually use aflibercept, brolucizumab, ranibizumab, and faricimab. Out of all these, the highest binding affinity with estimated half-life, high half-life, and low molar dose, which is required for the high affinity, and multi-target is solely aflibercept, and dual target is with the faricimab. With these all molecular properties, aflibercept has better efficacy, binding affinity, and half-life, and even potency. So in 2016, pivotal aflibercept trial demonstrated that PCV can be treated similar to neovascular AMD. One type of neovascular AMD is PCV actually. So the mean change in BCVA at week 96 pooled aflibercept arms, that PCV and non-PCV categories arms. In non-PCV arm, there are 9 letters gain, and PCV arm 11 letters gain by 96 weeks in the VIEW study. In the PLANET study, aflibercept without PDT and aflibercept with PDT. With PDT, there are 9 letters gain, and with monotherapy, single aflibercept 2 mg, there is 10 letters gain. So patients with PCV and patients with neovascular AMD achieve similar vision gains with aflibercept monotherapy. PDT can be reserved as a rescue therapy for suitable patients, but now PDT was not using in India. PLANET was a prospective sham controlled study assessing the efficacy of aflibercept monotherapy compared with aflibercept plus active PDT for the treatment of patients with PCV. In this, 62 centers they involved. 3 initial monthly doses of aflibercept 2 mg randomized into 1:1. So they have given aflibercept 8 weekly with sham PDT or active PDT when they are giving with aflibercept 4 weekly. So week 52 as a primary endpoint and week 96 as a study endpoint. So in PLANET, vision gains were maintained using aflibercept monotherapy with optional treat and extending dosing in 2 years. You can see in year 1, The baseline BCVA change was 8.1 letters and year 2 4.6 letters. Patients with extended intervals in year 2 maintained vision gains with a reduced treatment burden. And you can see here with monotherapy and rescue PDT nearly 84 and 80% with 11 plus letters gain and mean number of injections between 4.1 to 4.4. And by the end of 2 years, again, it was reduced to 60 and 57, but the injection number also reduced. The gaining of the letters were same. So in Altair, vision gain were maintained with aflibercept 2 mg, treat and extend in patients with or without PCV. Mean change in BCVA from baseline through 96 weeks. So we can see here with 2 weeks adjustment and 4 weeks adjustment, the in year 1, 7.1 and 6.7, and year 2 is 3.4 and 3.5 in the PCV group. In the non-PCV group, both are comparable, 7.2 and 6.9 in year 1 and 3.7 to 3.9 in the year 2. So Maruka et al. Reported similar outcomes with aflibercept 2 mg treat and extend through 2 years, regardless of neovascular AMD. So mean change in BCVA from baseline through year 1 and 2. PCV subgroup year 1 6.5 and year 2 also 6.5. In typical neovascular AMD 8 in year 1 and 6.5 in the year 2. So mean number of injections required also nearly equal, 7 in the PCV group and typical neovascular AMD 7.8. In the year 2, 5 injections in the PCV and 6.5 in the neovascular AMD cases. So real world patients with PCV can achieve vision gains comparable to those RCTs by comparing the Hosakova et al. And Mariazana Hosakova et al. Year 1, here it is 8 and here it is 9. So baseline also it is 66.5 to 65.5. But here it is at 12-week intervals at year 1. And here 16 weeks interval at year 2. When the duration was increasing, the even weeks Q16 also they are following. So complete polyprogression have been observed across real world cases series with aflibercept in PCV. We can see in multiple studies, Walt, Satio, Inos, Hosakovi, Oishi and Amento. They all given between 61 to 75% of regression. But the variability in polyprogression rates are likely due to difference in polyprogression assessment criteria across different studies. They compared faricimab and aflibercept in PLANET and Selvin study. But PLANET is a multi-center, double-masked and randomized sham controlled. Here it is an open label because of single faricimab was used and single arm. Here arms are two, monotherapy of aflibercept or aflibercept with PDT. Here only faricimab 6 mg only, no comparator. Masking here double mask, here is open label. And here regimen is 3 monthly loading dose, that is 0, 4 and 8 weeks. Here 4 monthly loading dose every 4 weeks to 12 weeks. So primary endpoint BCVA change from baseline to 52 weeks and here to 40 to 48 weeks. Polyprogression at 52 weeks they have assessed mostly complete or absence of polyps or absence of leaking polyps at 52 weeks. But in faricimab, polyprogression or inactivation only 77%, confirmed diagnosis by PCV. So aflibercept versus faricimab, PCV patients after 3 loading doses significantly better visual outcome observed with aflibercept. We can see here, even when eyes with all types of fluid, we can compare with blue one is aflibercept, that dark blue or black one is with faricimab. When the pre-treatment both are equal and the regression of fluid we can see 1 month, 2 months, 3 months, it is more comparable with the faricimab. And even polyprogression 44% and it is 33% with the faricimab. So by conclusion in HARAT trial, head-to-head comparison real world study in treatment naive neovascular AMDs, all patients were Japanese population. Both aflibercept and faricimab treatment are effective in reducing exudation and retinal thickness. However, aflibercept was more likely to eliminate exudative changes and improve visual acuity after loading dose. So both IV Intravitreal aflibercept and faricimab treatments are effective in reducing exudative and retinal thickness. However, exudative changes are improved with short term. While concluding my slides, aflibercept 2 mg efficacy and safety profile has been established across RCTs and is supported by over a decade of world PV monitoring. Greater than 20,000 patients from 20 countries treated in a real world studies, greater than 90 million doses since launch, greater than 1 decade of RCTs and real world and post marketing experience, greater than 13 million of patients a year of exposure, and the drug is approved globally for branch retinal vein occlusion and central vein occlusion, diabetic macular edema, macular CNV, neovascular AMD throughout the world. And in Japan, neovascular glaucoma also they accepted. And for ROP, USA, Switzerland, and Japan. And it has the lowest rate of adverse events with aflibercept and intraocular inflammation 1 in 10,000. Even endophthalmitis 0.6 in 10,000 units. And ADA data suggests that no association with immunological response. Thank you.
Thank you, sir.
Any questions, sir? Or can we go to other session?
Let's proceed with madam presentation, sir. Then we will start our
Sure.
questions. Harshita madam, is that okay to share now? Madam, your slides are visible, madam.
Okay.
Yeah, you are audible now, ma'am.
Yeah, I'm audible, but just 1 second. I'll connect from my phone itself. That is better.
Yes, ma'am. Yes, ma'am.
Are you able to see much right now? Srinivas garu,
Yes, ma'am, we can see.
Yes, ma'am.
I can hear
am I
you.
audible?
Yes, ma'am. Yes.
You are audible, madam. Can you make it full screen, madam?
Yeah, right. It is full screen, right?
Not. Now it's okay, madam.
Okay. I'm audible, right?
Yeah, you are audible, ma'am.
Okay. Good evening, dear colleagues. Let's today talk about translating research into practice, real-world applications of DME management strategies. These are my disclaimers. First and foremost, let us address the gaps between the real-world treatment outcomes and the randomized controlled trial designs. There are few gaps which we have to discuss. The first is the generalizability gap. For example, in the RCTs, strict inclusion and exclusion criteria are being followed, but while we are treating our patients, we don't pick our patients based on those criteria. Our baseline vision acuity in our patients is different, and also our patients have multiple comorbidities also. So, and the second gap is there is lack of consensus in the ideal treatment regimen among the physicians, whether to follow treat and extend or Prorineta. The third gap that we are seeing is there are real world complexities of the disease and its management. The complexities arise from the patient not being lost to follow up, transportation facilities, attenders should be there for few comorbid patients. All this comes under this gap. So let us come to the current landscape of anti-VEGF in the diabetic macular edema treatment. Currently, we have with us few trials which have already established that continuous and consistent suppression of anti-VEGF is required to maintain the excellent vision gains in the long term. For example, in the RIDE and RISE pooled study, it has shown that ranibizumab is very effective in gaining 12.4 letter at 2 or 3 years. In the Yosemite trial, they have compared faricimab 6 mg at Q8 intervals and Eylea 2 mg at Q8 intervals. They have shown that both of these drugs are effective in gaining 10 to 11 letters of vision improvement. In the KITE study, they have compared brolucizumab versus aflibercept, and both of those have achieved excellent visual gains in the range of 9 to 10. So, what we can translate from this into our real world practice is first one, as I told earlier, consistent VEGF suppression is required. Second one, to maintain the compliance of patient, we need a drug which is longer acting and also more efficacious right from the start. Let us come to the RCTs pertaining to the aflibercept in the treatment of DME. There are two main RCTs that we have to consider. And from these two RCTs, what we can take back into our clinical practice is three things. The first one, start aflibercept early in the patients with low visual acuity. The protocol T has specifically shown us that patients with low visual acuity are the ones who are more benefited from aflibercept right from the start. The second point is do not back off on treating the patients early and aggressively. The loading doses are very, very important. First, we have to give 3 to 5 loading doses, and then we can follow PRN regimen or treat and extend depending upon the patient. But if we shy away from giving the first 3 to 5 loading doses, we cannot achieve the excellent visual gains as seen in this Vivid Vista and DRCR.net protocol T. As we have seen the RCTs, usually the RCT visual gains are not so much comparable in the real world. So there is a need for real world data to complement data from the RCTs. So real world evidence provides essential information as to on patient impact, worldwide differences, regional differences, and the value of treatment. This is the endurance study, which is a real world study, but it is a continuation of the RISE study, which has taken ranibizumab into consideration. So in this study, the patients were observed at 4, 8, and 12 weekly intervals, depending upon disease stability. And they have found out that substantial reduction in the treatment burden through 2 years. The main important point to focus here is 25% of patients required no retreatment and 48% of patients received 5 or fewer injections. So what we can take back home from this endurance study is the durability. Aflibercept is most durable even at 5 years, provided we treat aggressively in the loading doses and the follow-up regimen is also strict. We can achieve highest level of durability with aflibercept. These are few of the regional studies that have been done in the real world evidence. Apollon study is from France and Moorfield study is from UK. What they have suggested is, what they have shown is, in the Apollo, 52% of treatment naive patients received early intensive therapy with 5 monthly loading doses. Even in the real world evidence studies, they have given 5 monthly loading doses and they have gained excellent visual gains even in patients with low visual acuity in Apollon study. In the Moorfield study, they have compared the same treatment has been given, but what we can know from this study is patients with lower visual acuity, with worse visual acuity lower than 20/40 have achieved 17 plus letters, and patients with better visual acuity at presentation have achieved 4 plus letters. These are also comparable to the real RCTs. This is a DRACO study, which is a real world evidence study, which tells us that maintenance of aflibercept and regardless of baseline vision, we can achieve meaningful vision gains. For more than 75% of patients, DR severity level remains stable from baseline to month 12. What we can take home from this study is that it is not only the macula that we are treating. It's not only the diabetic macular edema part we are treating. We are also concerned about the diabetic retinopathy severity level. The whole retina is, the VEGF suppression in the whole retina is also important. In this study, they have shown that more than 75% remained stable in terms of DR severity level. What about the cases where there is suboptimal response to aflibercept? They have done this study to show the aflibercept versus dexamethasone implant for recalcitrant diabetic macular edema in pseudophakic eyes. They have found out that both aflibercept and dex implants provide similar visual gains and central macular thickness improvements in recalcitrant DME. But aflibercept leads to more visual gain, that is more than 3-line vision gains, but it requires more injections and follow-ups. And we are also aware of that steroid implants are to be continued, the patients are to be continuously followed for IOP measurements and cataracts. So we have studied the RCTs and the real world evidence which are in the context of aflibercept. Now let us come to the guidelines. These are the guidelines from AAOS and VRSI. What they have suggested is intravitreal injections of anti-VEGF agents are first line of treatment for treatment naive center involving DME. We are all aware of that. And multiple clinical trials have demonstrated that anti-VEGF therapy is more effective in improving vision in central involving DME than macular laser treatment. But what is new to us is the most common reason for non-response to anti-VEGF therapy is due to inadequate treatment as per the protocols. In eyes with persistent DME, visual acuity of less than 612, a different anti-VEGF agent may be considered if the patient is refractory. If the patient has been on bevacizumab a switch to ranibizumab or aflibercept is recommended. And if the patient is on ranibizumab, a switch to aflibercept is recommended. And there are also many international recommendations from the other countries and guidelines. They all recommended the first line use of aflibercept in patients with poor visual acuity, less than 612. Few of the studies say that in patients with poor visual acuity, aflibercept may lead to more rapid visual improvement than ranibizumab. And also, there is an evidence for possible difference in drug efficacy in patients with DME due to disadvantage of bevacizumab at a visual acuity of less than 20/50. Let us study about the pooled RCT data. These are the meta-analysis which are the highest level of evidence. This Cochrane meta-analysis has studied 6,000 patients from pooled RCTs. And what it has found out is that at year 1, all efficacy outcomes significantly favored aflibercept over ranibizumab and bevacizumab. The most striking feature in this Cochrane study is that for every 1,000 people treated with aflibercept, 92 fewer would gain 3 or more line of visual acuity at year 1 if treated with ranibizumab. So aflibercept is more superior in efficacy, duration, and also tolerability, safety profile, all these things. Patients were approximately 30% more likely to gain more than 3 lines with aflibercept than with ranibizumab or bevacizumab at year 1. There are other meta-analyses from BMC Ophthalmology and PLUS, and what they are also suggesting is that aflibercept at 2Q8 intervals consistently showed evidence of superiority as compared with ranibizumab 0.5 mg PRN. So compared to the other studies, what this study we can take home from this study is we usually give ranibizumab at 0.5 mg dose, not 0.3 mg dose. So we can take from this study that aflibercept 2Q8 is consistently superior when compared to ranibizumab 0.5 mg PRN. And a PLUS study also suggested that aflibercept is most favorable treatment in terms of BCVA improvement and CMT reduction compared with other therapies in management of DME within 12 months. There are few other guidelines, and all these guidelines, for example, the EURETINA guideline, it has suggested that aflibercept is a drug of choice in DME with baseline poor visual acuity. We have been studying this from the protocol T. Through all these studies, aflibercept has been suggested as the drug of choice in patients with presenting poor visual acuity. Asian recommendations suggest that aflibercept may result in more rapid visual acuity improvement than 0.3 ranibizumab. German Society guidelines, they suggested that there is evidence for a possible difference in the drug efficacy in patients with diabetic macular edema due to the disadvantage of bevacizumab at a visual acuity of less than poor visual acuity, 20/50. This is what I've been talking. First, the highest level of evidence is the systematic review and meta-analysis, which we have studied the recommendations based on Cochrane study, BMC, and PLUS studies. The individual RCTs like VIVID, VISTA, and Protocol T are the next level of evidence. And then comes the real-world evidence studies, which we have seen, endurance study, and etc. And the expert opinion, the guidelines, all these guidelines have been taken into consideration, taking the individual RCTs like Protocol T, which is the standard that we follow, and also other RCTs into consideration. So when making evidence-based decisions for patient care, it is essential to select the highest level of research design available for specific question of interest. Recently, the DRCR network has been expanding with many protocols, and in all these protocols, aflibercept is considered the standard of care in comparing with different arms. For example, in Protocol W, intravitreal aflibercept for the prevention of vision-threatening DR in eyes at high-risk PDR. Aflibercept has been considered the standard of care. And in Protocol V, treatment of central involving DME in eyes with a very good visual acuity. Also, it has compared aflibercept as the primary drug. So, what we can take home from this is aflibercept is a drug of choice in patients with presenting poor visual acuity, in patients who can afford the drug, in patients who cannot come for regular follow-up visits, because it is a durable, and after initial loading doses we can maintain the aflibercept drug in a treat and extend regimen. Also, the 2Q8 and 2Q12 arms are also supportive of that. And in clinical practice, the same things are being followed, but with a slight difference. For example, our patients, when presented with the recalcitrant diabetic macular edema, what we take into consideration are the OCT biomarkers, and we suggest that okay, this patient is a poor responder, like that. These are how we translate research into clinical practice. Let us take up some questions. Thank you.
Hello, Annaji sir.
Yes, sir.
Any comments or question to ma'am?
Harshita ma'am, very nice presentation.
Thank
I
you.
think you elaborated very well, and it is very
Thank
helpful for the practitioners. How can we proceed with loading dose and treat and extend regimens?
you. Yes, yes.
Yes, ma'am. Any other comments, sir?
Ma'am, from sir presentation, if you have any comment, meanwhile I'll check the chat box. Dear
Sure.
doctors, if any question is there, please put in chat box. Madam, meanwhile you can have a word with Annaji sir.
Sure. Sir, as you said in PCV, it's a durable. We need a durable drug for treatment of PCV because we see many relapses. We see many reactivated PCVs and all. But in DME, it is a fine disease, according to me. And we don't tolerate any kind of IRF or SRF in DME. But what do you suggest in PCV? Can we tolerate a small amount of SRF, or we have to treat to dry retina? What is your opinion on this, sir?
I want to treat dry the retina, ma'am, than the
Sure, sure,
SRF, because the
sure,
polyp regression is more important. So
sure,
sometimes the polyp may not regress,
sure.
but still we have to treat the SRF there.
Okay,
And if there is no SRF, but still polyp is active, we
sure.
may treat and extend the regimen. I I will
Okay,
follow that actually.
oh,
But if there is
okay,
fluid, again I will treat. If not, I will
okay,
again treat and extend like 4 weeks to 8, 8 to 12, and 12 to 16 weeks.
okay, okay.
Okay. In the
Thank
longevity,
you,
we are
sir. Thank you
reducing
for
the.
clarifying.
Yes, ma'am.
Thank you. Thank you for clarifying, sir.
Are you giving loading doses, ma'am, in Vijayanagram?
Yes,
The
sir. We are giving loading.
anti-VEGFs?
Yeah, all PCVs, DMEs, we are giving loading doses. And depending upon the patient profile, we either follow a PRN regimen or treat and extend regimen. Usually,
What about
I prefer to follow PRN regimen only, but if the patient is insisting, I extend the intervals a bit.
RVOs and BRVOs? How we are treating?
BRV was usually, if it is non-center involving and all, we prefer to manage conservatively for 1 month. CRVO for gross edemas and all, we give loading doses.
Loading
Even
dose.
if the retina is dry on month 2, we prefer to give loading doses because the visual acuity gains in the long term, or the visual acuity gains in the acute phase, are also very high with loading doses. We have to suppress the anti-VEGF aggressively.
Yeah, I have seen in CRVOs, relapsing is too high if
Yes,
you
sir.
suddenly stop the anti-VEGF injections with 1 or 2
Yes, sir.
months.
Yes, sir. Yes, sir.
Ma'am, one case recently I have seen.
Sir.
Case of RVO given loading dose of anti-VEGF,
Okay.
but still the edema was not resolving, and
No, sir.
even the ghost vessels was appeared like more than 10 dd diameters, like ischemic. So you
Okay,
can have done PRP laser and given intravitreal steroids, Ozurdex implant.
okay.
Then after 3 months, again relapsing of the edema, and it was
Hmm.
worsened more than 500
Yes.
microns, 560. Now, how you will approach those cases?
Uh, Probably add more laser, add more grid laser,
Mm,
or even we can repeat FFA to see for other, because during primary PRP we don't we leave some gaps because there are more of hemorrhages. Those
mm,
gaps can be addressed when doing a repeat PRP.
mm,
What is your approach for such cases? As you said, recalcitrant or relapsing edemas in CRVO is a very common problem,
yes.
and we think once we do PRP for the periphery, it'll resolve on its own. But
Mm, mm,
it does not. It does not go away. Probably
mm,
a grid laser would help, or repeating injections is the only choice for that kind of refractory recalcitrant CMV. Or we can resort to more of loading doses. For example, if the edema has reappeared again,
mm.
instead of one single injection on reactivation, probably can we add loading doses,
Again,
three
3 or 4
loading
doses.
doses,
Yes.
3 or 4, 3 to 5 loading doses. Probably that will help in the long term. We
Mm,
have to
okay,
check.
okay.
What is your approach for such cases, sir?
Same, ma'am. We will do FFA
Same.
first
Okay.
and
Okay.
see for again the gaps and again neovascularization elsewhere
Yes.
wherever it
Yes.
was there.
Yes. Yes. Sir,
And
yes.
again, either steroid or better anti-VEGF molecule will be
Better
there.
anti-VEGF.
But the
Yes.
thing
Yes.
is, patient has to accept for
Yes, sir. Yes,
multiple
sir.
doses.
In a
Usually,
resource poor settings, that is the major difficulty we are facing. But still,
because
we'll try to do whatever is best for the patient.
when we see CRVO, looks like simple CRVO, we will tell that by giving loading dose, it may affect, it will resolve 90%.
Resolve. Yes.
So
Yes.
they will think that the 90% only they will catch it, and later they will ask us, you have given
Sure,
issues
sir.
that
That is a
within
real problem.
yeah,
And
three
even
doses.
in a CRVO, BRVO case with a, okay, in a young patient, they are more
Mm,
apprehensive in the working age group. They just
yes.
can't travel for repeat injections, and
Mm,
they keep getting apprehensive and questioning and all.
yes, ma'am.
That is the ideal situation where we can offer long-term, long-duration molecule like
Yes.
Aflibercept.
Srinivas sir, there is a question from Dr. Mamata ma'am that may I know when we get ILA HD in India or in at least Vizag?
Yes, sir. Yes, sir. So I am maybe I'll answer that, sir.
Mm,
Actually, sir, one good news is that we got approval from authorities for Eylea HD, sir, to launch in India, and company is in the process of like import and getting the package price and strategies, sir. So most probably, if everything goes on a right direction, company is planning to launch during VRSA, sir.
okay, in this November, December.
In this November, December. Yes, sir. Yes, sir. And drug will be available fully to the market, Indian market, by latest by December, sir.
Okay, same like that patient program will be there or
Actually, the strategy company is deciding, sir. I mean, designing. Definitely, there will be good strategy, and it will be approachable for your patient, sir, with excellent and exceptional long-term efficacy,
Mm, mm.
long-term duration, sir.
Okay, at the time this 2 mg will be continued or this will be discontinued?
No, no, this will be continued, sir. 2 mg will be continued with the same price because if any unaffordable patient comes for getting 2 to 3 months of efficacy, they will go ahead with this. And patients who would like to extend their treatment interval, they will opt for HD, sir. Both will be there in the market, sir.
And Dr. Vijay sir is asking about in refractive CRVOs, can we shift to farcimab versus steroids? How to decide the switch between both? Actually, for me, I will go for anti-VEGFs first. Any anti-VEGF. I will start from bevacizumab, and it may end with either Eylea or farcimab because these two are expensive. Now, Eylea has come to the affordable prices comparable to ranibizumab, so we can directly start with the Eylea injections. And at least I feel that 3 to 5 injections has to be given to know the refractory edemas or chronic CMEs. It may resolve with 4 to 5 doses, but a few cases where a lot of VEGF releasing factors will be there. We may need multiple injections, but patient has to afford or has to cooperate with the physician. In that case, we can go for intravitreal dexamethasone implant, which can stay for at least 3 months with sustained release of the drug. But we have to follow the patient very closely for looking for the IOP and cataract progression, especially IOP progression. And still, there is a chance 5 to 10% of patients after 3 months of steroid also recalcitrant edema can be there. In those cases, better to go with FFA or OCTA. FFA to see how much CNP areas are there, and OCTA we can see the macular macular ischemia is there or not, because if we are keep on treating the patient with multiple injections, and then in the end there is ischemia at macula, there is no use of giving multiple injections. So we have to assess both where VEGF load is there and where ischemic macula is there. So accordingly, we have to treat. And we may need, already Harshita madam has said that we should do PRP, but the laser mark should be little closer, like ROP lasers, but not very aggressive. But we have to do till the aura. Actually, till the aura. If not, there is a high chance of NVG. If needed, modified grid laser is required to see the leaking aneurysms and ischemic areas. I think Harshita ma'am,
Thank-
want to add anything, ma'am, about this refractory CRO cases?
The same, sir, the same. Because shifting to steroid probably can be done in a pseudophakic patient early, a little bit early. But then
Yes.
we have to be sure that the patient comes for follow-up for IOP check, because steroid-induced glaucoma is also refractory to AGM treatment. So we have to take that fine decision. But as you said, sir, and anti-VEGFs are the first line, because the main cause of that CME is the VEGF drive only. Inflammation probably might be the secondary cause. So as you said, anti-VEGFs with a potent anti-VEGF will be the first line in such case. Refractory cases also probably give more frequently. If the patient is on Q 4 weekly, probably a 3 weekly. If the patient is on 8 weekly, probably a 6 weekly injection can help probably.
And faricimab also can be given. This is the wonderful drug, because the
Yes,
question was about faricimab versus steroids.
yes,
I
yes.
feel that if patient is affordable, go with faricimab. The drying effect is
Okay.
very good, and even
Okay.
exudative lesions also, it was resolving very good with both faricimab and Eylea, that
Okay.
aflibercept. And steroids, very good, but there are side effects that we have to concern, and we have to explain to the patient before proceeding the case.
Yes, yes. I agree with this.
Sir, hope Vijay sir question was answered, and there are no questions in chat box, sir.
Yes, sir.
If you're okay, we can conclude the meeting, sir.
Thank you very much, sir, for giving this opportunity to both me and Harshita ma'am.
No,
Thank you.
it's my pleasure. It's my pleasure, sir, to have two wonderful speakers. Thank you so much for accepting, sir, and thank you so much all the other
1
doctors who
minute,
have
sir.
joined. Yes, sir,
Dr.
please.
Vijay has again given a question that when to decide aflibercept monotherapy and combination with PDT. Sir, actually, they have given APVRS 2025 with monotherapy and combination with PDT. But as of now, in India, we are not performing PDT in more than 90% of areas. Till 2022 or 2023, Arvind Coimbatore and LVP Hyderabad, Shankar Nathal Chennai, and Shankara Bengaluru was performing the PDT, but it is now like obsolete in our country. So we are going with anti-VEGF, solely anti-VEGF therapy. Or if it is extrafoveal lesion, we are going for laser ablation after the anti-VEGF. But we have to do, for laser ablation, we have to do at least OCTA or ICG with FFA to see the polyp.
Yes, sir.
Anything
To add on, sir, PDT is not available, sir. I think
Yes, sir. Yes,
in
sir.
India now.
Verteporfin, they have stopped, but again, I heard that it was coming to India again. The
Okay.
verteporfin, but the PDT they are not using because we got very good anti-VEGF drugs. Because of
Yes.
that, they are not using it. Again, we got yellow laser also. Because of the
Yes.
yellow laser, even they can hit the macula with nice resolution of the edemas.
Yes, sir. Yes, sir. As you mentioned, even Planet study also suggesting exclusively the monotherapy of aflibercept is much better than combination therapy.
Combination.
Planet
Even
study is also establishing that fact.
nearly 1 letter difference is there with monotherapy. That is the better than with PDT.
Yes, sir.
Even with PDT, sir, there are few side effects as thinning of the retinal layers following PDT. In a in a in a in a while treating the polyp, there might be over treatment, and then the retinal layers can get thinned out, which
Yes,
we
ma'am.
don't see in anti-VEGF treatment. So anti-VEGF monotherapy is a better option. As you said, PDT was never available anywhere because of that verteporfin dye was not being
Available.
produced.
Yes,
Yeah,
ma'am.
yeah. Yes. Thank you for that, sir. Thank you for the information.
Dr. Vijay, I want to add one more point. In PCVs and a few CNVMs, there may be a submacular hemorrhage you may can see. Those hemorrhages, treating those hemorrhages are little difficult to handle. So there you may need C3F8 and TPA injections with anti-VEGFs that you may keep in your chart box so that in future you may see those type of cases because we are seeing these days. Recently, I have seen even my post vitrectomy PDR case. After 3 years, the patient has presented with submacular hemorrhage with PCV. Again, I'm planning with TPA tomorrow with anti-VEGF and C3F8. So you have to think TPA also for submacular hemorrhages in these CNVM and PDR cases.
Sure, sir. Thank you, sir. Thank you, sir.
Srinivas sir,
Yes,
shall we
sir.
wind up?
Yeah. Thank you so much, Vijay sir. Hope your routes has been clarified. Thank you so much once again, Harshita ma'am and Anaji sir, for your wonderful talks. And thank you so much all the other doctors who spare your evening for the scientific event. Thank you once again, and have a wonderful time ahead. Thank you so much, sir.
Thank you, sir.
Yeah, tech team, we can conclude the meeting.
Thank you, ma'am. Good evening and good night to everyone.
Good evening, sir.
Can we close the meeting?
Yes, please.